Great. So I am Bernard Chang. I am an emergency physician who actually is also a psychologist. I did my PhD in psychology prior to going to medical school. So I kind of always had this longstanding interest with both mental health as well as acute care and emergency care. So my interests really have been looking at the psychological and behavioral effects stemming from COVID. Um, so what I'm going to do today is I'm just going to give you a brief overview of some of the work that's been done before, as well as some of the ongoing work here at Columbia, in addition to some future projects that we've been doing here within the emergency department at Columbia. Just a quick disclosure slide, just some of the funding we have from the NIH, as well as some advisory board work that I've done. So again, like I said, in the short 10 minutes, I'll hopefully give you a nice summary of some of the ongoing mental health work in COVID, as well as some of the things that are really ongoing here at Columbia. So the first thing is that I want to say that this is something that we've really been here before, both with disasters and previous pandemics. Going all the way back to the bubonic plague, the Black Death in the 1300s. You notice that the word quarantine comes from the Italian word quaranta, which is 40 days. So that came about when most of the sailors kind of doing trading along the Silk Road were quarantined, essentially kept out at port for about 40 days. And that the customs officers kind of figured out that was around a good time that it was safe enough for the incoming mariners to then kind of be evaluated and clear from passing this putative disease. They noticed also at the customs when they cleared at the 40 days that oftentimes many of these mariners showed not just physical impairments, but also psychological and behavioral health complaints. So at that point, they began thinking there might be something about this isolation and also this experience with being put away from society that could have led to some increases in psychological complaints. We also saw this with the previous pandemics we discussed before, with H1N1 and SARS, and in particular, healthcare workers have been the ones who've been very vulnerable. We've seen with the previous work that with SARS coming from 2002, 2003, that approximately 30 to 40% of frontline healthcare workers, nurses and physicians working in emergency departments, as well as like EMS staff, had self-reported depressive symptoms as well as anxiety symptoms. And what was really concerning about that was it wasn't apparent in the beginning, but then you reevaluated these individuals 30 days, 3 months down the road, and some of these individuals continued to have some of these symptoms. So the concern was that the psychological symptoms that you're experiencing in the crisis event not only is potentially long in duration, but something that can manifest in a different way, kind of like throughout the course. We've recently seen some evidence.
Bernard, this is Eric Green. You don't seem to be in presentation mode, and your slides are not advancing.
Oh, they aren't?
No.
Oh,
so if you can switch to presentation mode.
Yeah. Sorry about that. Let me switch back. Sorry, team. Presenter view.
We thought we were spending just a lot of time on the first slides.
Yeah. Sorry about that, team. Yeah, maybe what I'll do is I shared only for the PowerPoint. Maybe I'll just share my whole thing.
Yeah.
Yeah. Sorry, everybody. There you go. Is everyone seeing it now?
Yeah. No.
Okay, fabulous. So yeah, the disclosures, the objectives. We've been here before. Here's the first slide for SARS and H1N1. And so, like I was saying before, is that we've seen kind of with the earlier pandemics that there have been psychological effects from all of this, both especially for the healthcare workers on the front line. We've now seen some early evidence coming out of this current pandemic. We had a recent article published out from JAMA Open from some researchers in Wuhan, China, talking about some of the initial behavioral effects that you're seeing from the healthcare workers. What's concerning about this is you saw essentially about 50 to 60% of frontline workers were already endorsing some anxiety and depressive symptoms in the face of treating a lot of the patients in this pandemic. So how are we doing here? Here at Columbia, there's been some ongoing work kind of exploring what has been the behavioral consequences here in our system. And so I wanted to share some of the data that we have here. But before going into doing that, I just wanted to really just talk about why I think personally this is a very unique pandemic. I really call this a digital age pandemic. What I mean by that is you're seeing now, compared to previous pandemics, the amount of information sharing and the whole scale of government of which the measures to kind of prevent disease transmission and spread have really affected all walks of society. So for a lot of the frontline healthcare workers, you're not only dealing with it kind of working clinically, but then you also have to encounter a number of unique challenges, both with traditional methods of social support, as well as communicating with your loved ones or family members that could be additional stressors. I think in particular for the COVID-19 crisis here at Columbia, we face unprecedented staffing models. So in addition to having frontline workers like emergency physicians and EMS staff, and ICU physicians, we also saw a number of physicians who traditionally, or clinicians who traditionally don't work in the emergency department, having to be reshuffled and working along those front lines. So for those individuals, you can imagine that that kind of occupational environment, that acute care environment might have been a very different experience. We also saw a number of changes, obviously, with the acuity and the volume in terms of equipment too during the pandemic. So I think there was not only a fear for the well-being of the patients, but also a fear for the providers themselves. And so I think for many clinicians, these additional stressors really exacerbated kind of like the baseline stress that was already encountered in caring for the patients. There was a recent cross-sectional survey that we submitted. It's under review. That was a really great interdisciplinary project that was led by Dr. Zari Schechter in the Center of Behavioral Cardiovascular Health and Marwa Abdallah in cardiology. As you can see by the large author list, it really kind of involved a whole range of departments across our medical center, as well as behavioral specialists, acute care, and outpatient clinicians. So we really try to ask the question of what is going on from the behavioral and psychological standpoint for our clinicians, but also what are the potential interventions, or what are the potential resources that these providers would seek out, have been seeking out, and would be interested in seeking out. So we wanted to not just describe what was going on, but we also wanted to describe what potential areas for interventions we could examine. We took a cross-sectional approach, did a cross-sectional survey, tried to reach out to as broad a group of individuals as possible, so included faculty, trainees, advanced practice providers like PAs and NPs, in addition to nurses. So we had a potential pool of about 7,000 individuals throughout the medical complex. We also gave them, it was done online via Qualtrics, and we had them fill out a range of biopsychosocial surveys, both from validated anxiety, depressive surveys, including specific questions about COVID, personal protection, equipment, as well as kind of their strategies that they've used themselves. The results here so far, we collected for 657 participants. The sample is 70% women. In light of that, we were just thinking that about 50% of the participants were nurses, and which historically has been a slight gender skew. We found that about 40% are physicians and 40% were working in the critical care areas. And we defined that by the emergency department or kind of the critical care ICU regions. Just a couple quick graphs. We found, alarmingly, there were quite high rates of both anxiety as well as even PTSD, early PTSD symptoms. So we saw almost 40 to ranging to high 50% of individuals, both among attendings and trainees. Nurses in particular were very vulnerable to both some of the anxiety and depressive symptoms. In terms of talking about the coping behaviors that most of our colleagues were doing right now during the pandemic, we saw exercise was very high for many individuals, and they had a whole range of both kind of self-guided behavioral interventions, ranging from trying to talk to themselves, like yoga, like meditation, et cetera. But we also noticed, interestingly, that about a significant number of individuals were looking for virtual support. So just kind of tying into this idea of a digital pandemic, individuals were using unofficial WhatsApp groups or chat groups to really kind of reach out to colleagues and do peer-to-peer advice and counseling as well. In terms of proposed wellness resources, when we asked participants, about half of individuals were game for kind of potential interventions, ranging from either self-guided counseling or kind of more peer-to-peer support. Surprisingly, about a little under half of individuals didn't really answer this, and kind of left it kind of onto us to saying, what can you do to help identify, not just identify, but help manage this challenge. So I think it really kind of taking away the points from this is that really that there is this emerging crisis among our healthcare providers, and it's really kind of a pressing concern for us to really begin to identify and talk about specific interventions. So one of the things that we've been looking at here at Columbia is we've been trying to understand not just a pure snapshot, but also the development of both short-term and long-term, not just psychological outcomes, but as a health psychologist, I'm very interested in looking at kind of the interaction between both the psychology and the physiology. And so how does this potentially impact cardiovascular outcomes? There's been a lot of work talking about how psychological stress increases blood pressure, decreased heart rate variability, both independent predictors for cardiovascular risk. So one of the things that myself and Ari Schechter have been looking at now is doing a prospective longitudinal study of the frontline healthcare workers, looking at both psychological and cardiovascular outcomes. We're calling it IMPROVE, just with the hopes that we'll be able to identify some modifiable interventions for our colleagues. The way that it'll look like, we recently got this funded, and we were actually about to start the study it was funded by NHLBI, and just as we were about to get started for the study, the pandemic started and we had the research pause. So we're going to be starting the study up as soon as we get the green light from the medical center, and it will be involving a sample of frontline emergency clinicians, both nurses and physicians and advanced practice providers, looking at over a 3-year burst, both their psychological measures as well as blood pressure, in addition to sleep physiology, because we found that disrupted sleep could also be, of course, something with an occupational stressor for a lot of our frontline providers, but could also be a risk factor for the subsequent development of psychological and cardiovascular outcomes. So that was just a quick snapshot. I know that I had a brief amount of time with you all, but we just wanted to kind of highlight that I think that in addition to what our fabulous colleagues are doing from more of the basic science and from the virology, that the behavioral and psychological consequences from this pandemic are also far-reaching and quite durable, we're concerned about. And so some of the work that we've been doing here is really trying to identify potential areas that we can support our colleagues, and not just our colleagues too, because I believe that a lot of this work is really going to be affecting most of patients directly affected by COVID, but also broad swaths of society who have really kind of been under a lot of these large-scale societal changes over the last few months. So that's all I have for the prepared slides. So I want to give a lot of time just for any questions for anybody. Thank you very much.
Thank you, Bernard. This is wonderful. And you're right on time. Actually, the alarm is going on right now, so 2 minutes early. I'm looking at the attendee list. There's a question by Neville Kleins.
Yeah, hi. I hope I didn't miss it, but I was surprised that anxiety would be less common than even depression, and it raises the question of how you define these things. Did I miss the diagnostic classifications?
So we had used basically some PHQ-2 just for kind of self-report survey. And then for the anxiety-related questions, we developed a COVID-related stress survey about both exposure to COVID and kind of fear for COVID. So it was an instrument that we developed in shop for administration.
Thank you, Bernard.
Sure.
Not seeing any additional questions. Oh yeah, okay, Margaret.
Hello, Bernard. Thank you for a wonderful talk. It strikes me that some of the people that you may have been looking at, particularly frontline workers or so, and people from backgrounds of color, that they may already live with pre-existing, and this is all people, of course, but live with pre-existing levels of stress. And how does that play into how they might respond to stress under COVID-19? It may well just be another stress, so that the response isn't as much of an uptick as it might be in some other populations.
No, it's a fabulous question, Margaret. So the question just for the group is kind of looking at this idea of there might be some individuals within the participants who might be more vulnerable or less vulnerable, or just as a function of not just what's happening right now, but also from previous stressors or state trait characteristics. And so We didn't really assess it here for this cross-sectional survey, but in our longitudinal study, what we're trying to capture is both trauma history, anxiety history, in addition to a lot of demographic variables to kind of understand if there are any interactions both with a kind of traditional disparities of health, kind of interacting with some of the outcomes we're looking at. But I agree completely with you.